I'm going to tell you a little bit about diet and seizures today. I'd like to know, first of all, how many of you have been prescribed or have self-prescribed a diet for seizure disorder? All right, a couple. All right, very good. So there's a lot here for you all to learn. So today we're going to talk about ketogenic diets. We're going to explore the history of the ketogenic diet. We're going to define what that is in detail. We're going to discuss the efficacy or how effective this diet is in controlling seizures. And then we're going to talk a little bit about a couple of alternatives that have been researched more recently that are a little bit more easy to operate with families and folks that are on these diets. That's use of medium-chain triglycerides, which really is a manufactured fat from coconut oil. We have the modified Atkins diet, and also the low glycemic index therapy. And so each of these diets are starting to be researched and used more in both child and adult seizure disorders. So I'm proud to say that this is the Plummer Building here. The Plummer Building's in Rochester. So Mayo Clinic in 1921, Dr. R.M. Wilder was the first on record to publish and talk about the ketogenic diet. And basically, this is a high-fat, low-protein, low-carbohydrate diet that mimics starvation, which had been previously shown that to put someone on a fast 48 hours, 72 hours could help with seizure reduction. The benefit of this is that you could actually mimic starvation and still eat and still have a similar result. So that's the first we know of the ketogenic diet. Essentially, it's a diet that produces ketones or ketosis. As the bottom point says here, those who are using ketones as primary source of energy are said to be in ketosis. And what happens is, in the absence of carbohydrate, which is our primary energy source, when we start burning fats as energy, the byproduct is ketones. And this is very, very important as humans evolved over time, in that when we, as an early developing being, would go long periods of time between food sources. You know, we might, as we were hunters and gatherers, we might come across a harvest and eat, or come across a group of animals and be able to feast and eat. And then we'd go long periods of time as we moved on in a semi-starvation mode in order to find our next meal. Well, the body developed a way to utilize our fat sources to burn energy and to create these ketones, which help us with energy during periods of starvation. So they are a great source of energy. They occur in the absence of carbohydrates, and they are a key energy source for the mind of the brain, which is why a lot of the research has been going into how do ketones impact how our brain functions. Ketone bodies, we do know that they produce anticonvulsant properties, but sustained ketosis is required, which means that if you bounce out of ketosis, you have too much carbohydrate in your diet, you will go out of ketosis, and then you won't have enough ketone bodies there to work. We also know that glucose restriction works and calorie restriction, and to some regard then, this is how our body takes in, utilizes glucose and turns that into energy. We call that glucose homeostasis. And we know that the restriction in the glucose itself limits the neuron's ability to reach the high levels of activity that are required in seizures. So perhaps it's ketosis, but perhaps it's also this impact of glucose restriction. And then these ketonic diets are very high in fat, up to 90% in fat. And this higher level of polyunsaturated fatty acids that's found in these diets are said to perhaps block seizure by reducing the neuron hyperexcitability. So there's the three main things that earlier really convoluted slide showed, which may be reasons why it works. So here's some consensus. The reason why diet's not primary therapy was talked about in several of the other presenters today is that 50% will respond to one medication. You'll have a little bit better response to two medications, and then there's some other treatments like the vagal nerve stimulation and the surgery. And so a good number of these patients will respond, about 66%, without having to develop a diet. However, 20 to 30% have refractory epilepsies, and these patients should be considered for a ketogenic diet. It is medicinal in its function, and it does work for a good number of people. The other thing is a lot of folks, as we see more adult seizure disorders, have felt like ketogenic diet or diet therapies were only for children, and in reality we know that they can work across the lifespan regardless of seizure type or etiology, which is cause, regardless of age, and it appears to provide some seizure reduction for about 90% of patients, and for about 1/3 they may be seizure-free. So that's pretty good. Who are good candidates? Again, we do not use this as primary therapy. We want patients to have tried other therapies, but when you're not responding to meds, you have intractable seizures and so forth, this could be a last resort that you would go to. There are some exclusionary criteria. There's some inborn genetic and metabolic deficiencies that we would have to rule out. If you already have significant kidney problems with kidney stones and that sort of thing, you may not be a good candidate. Older patients who want to start this that have advanced heart disease, obviously because of the high level of fats, might not be a candidate, and so forth. So these diets do require medically supervision, and we call this a medically supervised diet. Classic ketogenic diet basically requires you to be in ketosis, and that shows you can buy the little ketone testing kits at your pharmacy and so forth, and that will basically test your urine pH to tell if you're in ketosis. 80 to 90% of the calories are from fat, so it is a very, very high fat diet. And what we try to do then is the other remaining 10 or 20% are all coming from your other two macronutrients, proteins and carbs. And we'll tend to start you on a ratio of about 2 to 1, so 50% carb and 50% protein, 50% fat, 50% protein and carb, and we'll titrate that up over time until your graph looks like predominantly fat with a very small percent. And I'll show you a nice graph here a little bit that shows you that. It does require close monitoring of glucose, electrolytes, and hydration early on, and so most centers, if not all, require hospitalization to start you on this diet so that we can monitor until you're good. There are some centers that have started that transition you to the outpatient very quickly with a much more gradual approach, and they have shown that you don't have to have this 3-day massive start to the diet to necessarily be successful. You can do a little bit more of a gradual approach, and that's gaining some traction. Well, how effective is it? In this particular study, those that were initiated on the diet at 6 months, 66% were still on the diet, so fairly good. The rest of those that dropped out, we call that attrition, and they drop out for a number of reasons. Lack of tolerance to the diet, whether it be GI upset or so forth, lack of resources to continue the diet therapy with a dietitian and so forth. But 66% are still on the diet, 41% had 90% seizure control, another 35%, greater than half, 50% seizure control, and a small drop off of about a fourth that had less than 50%, which maybe we consider a failure medically. But however, if you're that individual that's having the seizures, maybe that is even enough to show some benefit. And then those are the numbers at 12%, so you do have pretty good response to this type of diet. So some discussion about the diet. The neurologists, they believe that it takes about 2 weeks to respond. It's a gradual increase to get to ketosis, and it does take a little while to reset those genetic factors that and those biochemical pathways that make it work. So like a lot of medications, they take several weeks to work. The diet's very similar. But we do say it should be, if you're going to try it for at least 3 months, because just because you're not an early responder doesn't mean you're not going to respond. Without response in 3 months, we try something else. We think maybe the diet isn't going to work. We do believe that the diet is both works well for glucose control because of the ketones and the polyunsaturated fatty acids, but also calorie control tends to be important also. And if you can, even if you stay in ketosis, exceed too many calories, you can have issues. So calorie restriction tends to play a role also. And then this one's a big one, is that, everybody, all of us have tried diets before, whether it be for weight loss or any other ailment, primarily weight loss, and we all know that we cheat, right? And so the problem with this diet is that if you sneak just a little bit of carb, that can cause what's called a breakthrough seizure and really set the whole therapy back. So it's important that you follow it very strictly. Some nutritional shortcomings. We do recognize that this diet is deficient in some vitamins, minerals, and nutrients. When you take fruits and grains and a lot of those foods out of your diet early on, you could have some vitamin mineral deficiencies, so it does require some supplementation. We recommend universally a multivitamin with minerals and calcium and vitamin D. You can, to treat some of the side effects like constipation and that sort of thing, you can have some laxatives. A certain percent of patients will develop carnitine deficiency, so we have carnitine that we would check those levels. If you are deficient, we would give you carnitine. The use of MCT oil we'll talk about, and then oral citrates to help prevent kidney stones. Side effects include, and you hear this at the end of every commercial, you usually hear it, like side effects include constipation, vomiting, diarrhea, abdominal pain, reflux. So those things do happen. Metabolic, you can have some low calcium, magnesium, carnitine levels. About 11% increase in cholesterol levels was seen in some of these studies. Slowed growth, especially in younger children, could occur, and decreased amino acids and protein level stores. So again, it is medically supervised because we need to be checking these things along the way. Patient responsibility. Well, I've had a couple of calls just this week on these various diets, and one thing is that you do establish care primarily with a neurologist who is helping to manage your seizures with the medication, so that they know you're going to try one of these diets, and so that they can help do the lab work and so forth. It helps to have a dietitian. The meal planning can become difficult. There are some online resources which I'll share to you at the end, but it's very helpful to have someone manipulate the numbers, especially the ketogenic diet, which is these 4-to-1, 3-to-1, 2-to-1 ratios can be a little bit difficult. It helps sometimes if you have a social worker or a behavioral psychologist like Dr. Cox, that can sort of help with the family dynamics and that sort of thing and how all this is going to work. We do bold in red that not to try it on your own, because some of the fluctuations in your hydration, your electrolyte levels, and that sort of thing could be catastrophic without being managed. Strict adherence to diet and follow-up is certainly key. So in conclusion, there's several mechanisms that work. The one slide that I showed you there with all the hormones and pathways and that sort of thing really is a theoretical model. We thought ketones were the key, and now we understand with low glycemic index that it might be a more complex model that works for different people. It is important to know that the recent studies and the newer literature is showing that more liberalized diets are possible. And so I've talked to families that said we would never try the ketogenic diet. We just couldn't make that work for our family and so forth. And these newer models out there are very promising in allowing a diet that that the child can be a child and the family can be a family and so forth. It's important to work with your team to try to find where your limits are and where you are at. We think and we hope to study this, that we might be able to, with a combined modified Atkins and low glycemic index, get patients over that 30-gram model and still have good results. So there's that. What would a sample menu look like? Sausage and eggs for breakfast, a tablespoon of butter, coffee, a tablespoon of cream, and so forth. So for all of us parents who are struggling with weight, isn't that our diet already? So 8 ounces of grilled chicken with salsa, cheddar cheese, broccoli, olive oil, and an unsweet tea. Dinner's a 6-ounce steak with a 1/3 cup of green peppers cooked in olive oil. Again, you're seeing that we're adding those heart-healthy fats in. Cup of spinach leaves with 2 tablespoons of red vinaigrette. I like that with a little saute in that in a pan with a little garlic. That's awesome. Serve that at one of our meals here one day. So there's a sample menu. There's a couple of other days in there, but you guys get the point, and I'm glad to be here with you today.